Thank you, and thanks for this opportunity. My talk is biomechanics. Has it failed us, or do we know it better? These are my financial interests. In the interest of time, because I know we have only 5 minutes, I'm not going to go into
Oh, no,
depth
you
of
have
all
7 minutes.
7 minutes. So let's not going to go too much into all this, but people who use Pentacam and Corvus would probably understand these indices. The indices of bad D, which is there from your Pentacam, the CBI, your Corvus biomechanical index, and the topography based biomechanical index. And cutoff for this has been quite good, depends on who is publishing. Renato Groups publishes this, Vinsugura's group publishes this. So it always depends on who's publishing. This differs. Reasons why biomechanics is confusing and makes us feel we have failed. This is very important part of today's discussion. One is we are looking at the viscoelastic properties of the cornea. It depends a lot of hydration. It depends a lot on intraocular pressure. Depends a lot on repeatability of the scan, the quality of scan, the strength of scans. All this somehow we miss when we do a biomechanical assessment, because it doesn't give you like a Pentacam or a topolizer or a Placido. It doesn't just show up that your scans are bad. For example, we all know about this concept about elastic, the viscoelastic nature. The hysteresis was what was coined with the ORA. Now, they spoke about two components. Deformation amplitude was an important thing when we started with Corvus in the late 2010 onwards. But now the concepts have changed. We really moved on. It depends a lot on the hydration state. And that's why, sometimes we make real mess of how we understand the biomechanics. Intraocular pressure plays an important role. This is the right and the left eye. The intraocular pressure in the right eye is 7 millimeters of mercury. And the CBI, look at the CBI, the intraocular pressure in the left eye is 18 millimeters of mercury. The stronger your intraocular pressure, the difficult it is to deform. So one of the reasons we don't understand is we have somehow missed putting all this together and looking at the biomechanic tools. I don't know why the glaucoma people are evaluating. There's only a small difference in the PACI, but the intraocular pressure is different by 10. And look at the indices. So never look at the biomechanical indices without understanding the intraocular pressure. So this is the first thing why we make mess out of this. Repeatability of scan is very important. Any of these things means that your scans are poor. You look at the maps. This is noise. When you have noise, you will always get a different biomechanical measurements. Never look at the scans, repeat it again. This is the confusion why makes a lot of people feel it's useless. Your bad D is abnormal. These two are normal. Or your CBI is normal, TBI is normal, and bad D may be normal. Now, what do we do with this? This is a confusion which we have. We are having this confusion because we are all blind men looking at one aspect of it and trying to make an assessment of a particular disease, of a particular type of corneal viscoelasticity. So what do we do with this? What's the true picture? Let's discuss one case for interest of time. This is a patient who has a bad D being normal. It's on a suspicious side. This is normal, and this is on the borderline. And you can see all of them are speaking differently. And you have a huge bump here. Now, epithelium is normal. You don't have to worry about it. This is where I call about the elephant. If you are looking at one aspect of it, you call it normal. If you're looking at a biomechanical aspect, you will call it normal. So there is this confusion which keeps happening. The last 2 years has been extensive work with collagen imaging. And this is a different topic by itself. It looks at like how you had the GDX, looks at the collagen polarization. What you see in darker shades of blue is normal. And what you see is the peripheral fibers like you see here. So we started looking at all these images and trying to see, does it match with your corneal biomechanics? That's when you start feeling that you understand the biomechanics very well. For example, the bad D is abnormal here. The CBI and the TBI are more or less normal. So now the question is, what do you expect of the collagen? If you go by the biomechanics, your collagen should be normal. If you go by the topography, it should be abnormal. Now, let's go out and look at the elephant as a whole. Then you see the collagen here matches very well with what is normal. So this collagen is actually normal. Maybe this small changes, and this patient also had a small posterior elevation, was probably because of epithelial thickness or changes. So this is one of the reasons why you have it. Now look at the second case. It's a very interesting case, and this is where the biomechanics plays a role. The band is normal because you have a perfectly normal cornea. Suddenly you see the CBI and TBI, both CBI is actually on the red. This is on little bit bordering. You can call it normal plus or minus abnormal. Now, what is happening here? Why is this a change? Now let's look at the collagen. The whole central collagen, the polarization is poor. I don't call it loss, it's poor polarization. And just look at the comparison here. Now, after this, we can discuss this particular case. Now you tell me, is it our understanding which was poor or the machine was poor? I personally feel it was understanding because we needed technologies to actually prove. And as we move on, give me 4 or 5 years, then we'll have more data. Then we'll probably have an algorithm for this. But at this point of time, I personally feel there is a good amount of data to support that, at least in 80%, 85% of the time, the biomechanics is telling the truth, especially in these cases, because you know that this is a normal looking eye, but a weak cornea. So just don't ignore it. So how do we prove that this is whatever I'm saying is still the truth? Same patient underwent the PRK and we did the molecular assessment. When you did the molecular assessment of this, what we were saying was true. When we did the molecular assessment of the same cornea with a good collagen, the collagen and the lysyl oxide, all the markers I've been talking about for many, many years were all normal. But look at the collagen of the same patients who had a poorer collagen. I did the PRK. I know that this is going to be stable, and these were all completely abnormal, which says that the biomechanics was actually telling the truth. You can see the biomechanics here was very poor. I can see those changes out here. The future is all about prediction. I don't want to go into this. We build the software. This is probably going to be part of the Oculus Pentacam, where you look at the different level of stiffening of the cornea. We are not looking at one parameter. This is a mathematical model driven. It comes in newtons per meter. That means your spring model is used, not just deformation. It looks at multiple parameters and has its own assessment. It tells you if you do a PRK on a particular patient, does it fall into an ectasia zone of weakness or in the normal zone? And you can put different things. You can write PRK, LASIK, SMILE, extra, whatever you want to do. And this is how the biomechanics is going to go in the future. A small algorithm about how we plan to do it. When you have biomechanics normal and structurally abnormal, consider PRK. When biomechanics and structurally both are abnormal, then you can look at an ICL as the procedure. These are the team with whom I work, and they helped me to make this presentation. Thank you. I will close my presentation now.